Dear doctors and friends, I welcome you all to this presentation and talk on the future of virtual clinics. I'm Dr. Srikant Kain, Managing Director of Sarthi Superspecialty Knee and Hip Center in Bangalore, India. And at the outset, I would like to thank Dr. Ismail Saeed, who is CEO of Vio Healthcare and a truly global citizen. It was indeed a pleasure to have met him a couple of years ago in Dhaka when I went for a meeting there uh, with a few professors in the Vishwangu Institute in Dhaka. And he's somebody who has done his, basic medical training in UAE and trained in management not only in UK but also in Australia, and also having worked, I think, in Chicago in US. So he's a truly global citizen, and it's a pleasure to associate with people like Dr. Ismail Saeed. About myself, I would like to say that my name is Dr. Srikant. These are my qualifications, and I'm particularly proud to have worked in Wrightington Hospital, the birthplace of joint replacement surgery in the world. And I completed my FRCS trauma and orthopedic training from Royal College of Surgeons in London. And I also did fellowship in computer assisted knee hip surgery, revision or redo surgery, and also robotic knee hip replacement surgery at Plymouth Teaching Hospitals. And at present, as I said, I'm a proprietor and managing director of Sarthi Superspecialty Knee and Hip Center in Bangalore, India. And I also did a infected revision fellowship in Endoclinic Hamburg, Germany, which is the mecca of single stage infected revisions in the world. I'm a member of several prestigious organizations like British Association of Knee and Hip Surgeons, the British Orthopedic Association, Indian Orthopedic Association, and British Orthopedic Research Society. What is telemedicine? What is my definition of it in a pandemic? So, to keep it simple, it's a practice of medicine respecting the social distancing and the lockdown norms prevalent in the different parts of the world at present. But as the name suggests, tele means remote and medicine is practice of medicine, where the doctor and the patient doesn't meet physically, yet they exchange medical knowledge. How has COVID affected my practice? So due to lockdown and social distancing norms and seal down and various other measures as the government had to take, there's definitely a reduced number of walk-in patients who used to just walk into the clinic before the COVID era. And this has very strangely brought order to my appointments, and it's become a bit more like the UK practice where every patient had to book an appointment through my secretary to come and meet me. And it's instilled a lot of hand and respiratory hygiene among my staff, myself and my patients. And masking has become a compulsory thing now. And the basic concept of SMS has come into place, which means social distancing, masking, and using sanitizers has become a bread and butter of everyone's life, including my patient's life. What are the obstacles to specialist healthcare for the patients before the Corona time? BC means before Corona. So I think the biggest challenges patients had before Corona time was finding the appropriate consultant to see. That was the biggest challenge, particularly in the developing countries. And this is basically due to variability of training from place to place, city to city, you know, which results in a different kind of advice given to the patients for the same box standard condition. Say, as you know, I was in UK for nearly 13 to 14 years. I was a consultant there for a long time. And the way NHS is structured is that, excuse me, we have primary care where the GPs see all the patients, and if they see that there is a knee arthritis patient, then they look at which is the secondary hospital near to them, and try to find out who are the knee surgeons present in the hospital, and make a referral to one of the surgeons who has got a shorter waiting list, so that it benefits their patients. And then the letter comes to the secretary; she will send it to me. and have to say which is an emergency, which is urgent, which is non-urgent, and give them appointment accordingly. This is a very, very organized system and a proper referral pathway. There's no hidden things there. There's nothing under the table here. But, in the developing world, what we see is a very poor referral practice and pathway. And this leads to delay in the patient reaching the consultant. And also sometimes if they end up in the wrong place, they get the wrong treatment and surgery done, which leads to much more complications. In England we have a concept called a grift, that is get it right first time. So when the surgery is done, you need to do the best you can and the right surgery, so that will be the last surgery for the patient, so that they don't come back every year for a revision or a new surgery for the same problem. So, the other challenges are how patients can verify the qualification experience of the consultant or the doctor. It's a very big question mark in the developing countries. But in UK, that's not an issue, because everybody in training, goes through a 6 years rigorous training. At the fourth year, they do the same FRCS or exit exam, where the same standard of questions are asked for every orthopedic surgeon in the country. And then 2 years of specialist fellowship there too, to obtain super specialty training in joint replacement or computer assisted surgery or robotics or hand surgery or spine surgery. Then they go on to become a consultant. So, uh, you know, the qualification is easily verifiable. And then when they see a patient for a box standard condition, they give the same advice anywhere in the country. And it doesn't vary grossly from place to place, whether it is London or Manchester or Birmingham, it's the same thing. So other challenges the Indian patients face is traveling distance. I get patients from Calcutta and other remote parts of West Bengal, and for them to travel all the way to Bangalore is a big challenge. And one of the gross that I hear patients telling, particularly in India, is that the time allotted by the senior most consultant or patient is very less. Sometimes they have team and the juniors see, and then they say senior gets only a few minutes to make a decision. But sometimes if there are problems that the juniors can't address, and the senior consultant has only 3 to 4 minutes to see the patient because of his workload, and the patient gets dissatisfied. And I believe in giving time to my patients, because that's very important. Without understanding them, however much other people might have seen, it's not optimum. So I believe in giving time to my patients, and that's very important. So what are my regular patients? How are they contacting me now? Post lockdown. See, around second week of March, India went into a full lockdown, and there'll be several phases of lockdown. On 20th March 2020, the Indian Medical Council, or Medical Council of India, made telemedicine a legal entity in India, because there's some confusion due to Supreme Court cases, and then that was made a legal entity. So since then, around 80 to 90% of my patients are coming through the e-consultation platform, and remaining are coming through regular clinic as before. What steps have I taken in the clinic to make sure that it's safe for the patients, as per government guidelines? So all the patients who come to the clinic, majority, as I said, come through e-consultation. So, they have to book appointment through the e-consultation. And that gives me a chance to know my patient, the area they come from, and the practical issues they might face coming from their place to my place, because their place may be sealed down, or in between place may be sealed down, or even place around my center may be sealed down. So can they access me? So that gives a big advantage in knowing them and giving the appointment to these patients. Then all of them are made to follow the SMS protocol. That is, sanitize, wear mask, and social distancing is a must even in clinic. And all of them are encouraged to download Arogya Setu app from the government and keep the Bluetooth on, which tells who are the other COVID patients around them. And they have to register in the reception with their Aadhaar card and the phone number, so that the government is asking us to send all the details of the patients coming to the center every day, and we do it on a daily basis. And only one attender is allowed per patient, not many as in the past. And I wear a PPE depending on the the situation. But basically, I do have a N95 or 99 mask and a face shield and gloves as a mandatory. And sometimes I have a surgical gown, depending on the patient, on the examination I need to do. But patient wearing mask and maintaining social distancing in the clinic is very important. And we also take time around 10 minutes to sanitize between patients, all the places where they're sat and the examination couch and everything. So what are the recommendations to private practitioners in Bangladesh to ensure safety? So I would like to say that, don't underestimate this virus. This virus has been a lethal killer, and please don't underestimate it. Say it is like as a normal flu or H1N1 or something like that. So, our Prime Minister said, "Jaan hai to jahan hai." So, if you are alive today, this year, you can serve hundreds and thousands of patients next year. But if we are no more there this year, then forget about our protecting and helping thousands of patients. So, the basic dictum in a pandemic, as expressed by all the world-class experts, we done, I was telling Dr. Said that we've done close to 60 webinars in the last 3 months of lockdown. All of them, majority of them are international. And this is the consensus that, as a doctor, you need to protect yourself now in a pandemic. Then you need to protect your team. And then you have to protect your patients. And in this order, it's very important. You try to change the order, you get into trouble. In the past, we used to always say protect the patient first because we didn't have any threat to our own lives. And, so now this order has changed. And this order is very important to make sure that you protect the patient. Otherwise, you break this chain of the order, you will end up troubling and infecting your own patients and yourself. So, and other important thing is follow all the guidelines that I just mentioned in the last slide. The most doctors are at risk in the OPD and the wards and not in the operation theaters. And definitely COVID ICU, I was speaking to an intensivist a couple of days ago. He said COVID ICU is the safest place in the hospital to work, almost zero chance of infection. I said, why and how? He said, see, basically, these patients don't come unless they are 7 or 8 or 10 days post-infection. Then only they become unwell, get the cytokine storm, and end up in ICU. And usually after 7 to 8, 9, 10 days, antibodies are produced in the patient's body and the viral culture will become negative. So no longer the patient is infective at that stage. And when they are there in the ICU with COVID, cytokine storm, they are almost like immune and they are not transmitting the virus to us. And then we have got full PPE. So we not only have full PPE, but also because of the delay in them coming to us, they are already immune and non-infective. Hence, COVID ICU is the safest place to work, contrary to the belief among doctors. So, other thing is PPE protocol you need to have, and particularly how to donning on of the PPE. More importantly, doffing off the PPE with a buddy system, with somebody who's watching you how you do it. These are all should be protocol driven, and that's the only thing which is going to save us. So let us look at the benefits of the telemedicine for patients. Basically, one is it is safe for patients in a pandemic because many hospitals have become centers of spread for corona and it could be dangerous. So it's safe for the patient in pandemic. It can be done from the comfort of their home. There's no need to travel. It saves time and no PPE is needed and they don't need to come with a mask. And it saves money as well. So what are the benefits of the doctor? It makes your practice more organized because it's all appointment based. 10 patients are not coming at the same time, waiting for you at the same time. And healthcare workers are 33% more prone to infection compared to normal people or patients. And it reduces the not only morbidity but also mortality associated with these infections for the healthcare professional. And the possibility of being paid before seeing the patient is there because of e-consultation, which was always the other way around sometimes. And it reduces the expenses on the PPE. And if a doctor has to travel to multiple sites, then the travel expenses are reduced. What are the 5 challenges in telemedicine? See, the biggest challenge is not able to physically examine the patient. And but this can be circumvented, because as I said, 80% of diagnosis is made in history. 20% you need examination, but you can, check the movement in the orthopedics of the patient, and also you can order investigations, and that can cover this 20% unable to examine the patient. So this not an insurmountable problem. The next challenge is patient and doctor identification. How do you identify if it's a genuine patient or it's an imposter? Or how do you identify if it's a genuine doctor sitting at the other end, or it's a nurse or a compounder or some lab technician who's having a white coat and posing as a doctor? And that's a challenge, it needs to be addressed. Consent, has to be taken for teleconsultation legally, and if the patient calls you or the somebody like Vyas calls you, it's implied consent. So, but how to take explicit consent? If you are calling patients, how do you take explicit consent? And what are the legal things which has to exchange for the consent to become explicit? That's a challenge. Data confidentiality is very important. We live in a world where there is increasing cyber crime and security threat. Just yesterday, India banned all the 59 Chinese apps, including TikTok. And this is a very uncertain world. So the data, if given to the patient, if it gets breached, or if it gets breached from the doctor's end or through Vyas end, what is the liability? That becomes a very important thing. And cybersecurity is a big challenge. And second, last but not the least, is ethics and the medical legal aspects of telemedicine. That is, usually a well-trained doctor, would not share the patient's data or videos to other people. And these things have to be thought about, and we have to have foolproof mechanisms by which, the ethics is not breached and the medical legal aspects of that particular country is not breached. How should you provide a prescription? I think the key thing is to identify the right patient, not an imposter, and check that you're taking the consent, you've written the right diagnosis and differential diagnosis, because these are all suable in India. And if you don't write the diagnosis, differential diagnosis, you can be sued. Don't take the consent, you can be sued. Do not check the patient details, you can be sued. And then a very important thing is history of allergy or past medical history. You have to document it. Although you may be a senior most doctor, introduce yourself, use lay terminology, no jargon on what you write, and prescribe on the letterhead, with your medical council number. This is what the government has recommended. And you send that slip by a PDF, non-editable PDF, or by JPEG images, by the e-consultation portal. So what is the important history taking video consultation? And this, I would say, is the most important part of video consultation. We did a study in the UK, devising Marseille's examination for the juniors for Royal College of Surgeons in the UK. We discovered that around 80% of diagnosis can be made by accurate history taking. 20% you can make up by investigations. So history is very, very important. What do you understand by bedside manners? Basically, bedside manners are the mannerisms taught to us as doctors, even as medical students, and it makes the foundation stone of our professionalism as a doctor. It has vital components like the way you dress, you approach the patient, how you communicate, how you make eye contact with the patient, how you respect the individual dignity of the patient. So basically, treat them as you want to be treated yourself. In short, that forms the bedside manners, in my understanding. Should a doctor charge the same for teleconsultation like regular consultation? If so, why? I think in my view, absolutely there should be no difference in the charges. The reason is a well-trained, professionally competent doctor should be able to give the same quality of care, same standards of care, irrespective of if it's a physical consultation or virtual consultation. You don't drop your standard just because it's a virtual consultation. So virtual consult is a new normal, and we need to change our mindset and to embrace this future, which is actually present now. It's not even future. It's here to stay. And we know the coronavirus is not going away, and it's here to stay for the next 3 to 4 years. So we have to learn to live in a world of lockdowns and social distancing from time to time. I was just telling Dr. Saeed that our city, Bangalore, went into sort of semi-lockdown since yesterday, after opening up. And again, we are hoping for a big full lockdown to happen on 7th July onwards, when the board examination for the 10th standard is finished. So this is the new normal. So how long should we see the patient? This is based on the recommendation from my NHS practice. I think for first consultation, it should be around 15 to 20 minutes time you need to see the patients, and for follow-up should be around 7 to 10 minutes. So that's how clinics are slotted. But it varies from specialty to specialty, and if there is a second opinion, which is common, then it takes longer time. But in India, we get very bizarre experience of 10th opinion, 15th opinion. And that takes a long time because you have to look at what all the 15 doctors have said before you, before recommending. So obviously it will take probably an hour to consult such patients. Uh, Patient's condition suggests you have a serious problem. What do you do? And say, this calls for immediate attention. The patient is calling from a different city. You need to ask them to go to the nearest hospital and take treatment. If the patient is calling from near your place, you can ask them to call the ambulance, come to your casualty, and your team can see them, stabilize them, and admit them, and you can go and sort it out. So, how will you manage a hostile or uncooperative patient? So, first you need to identify that it's a patient, not an imposter. If there are any organic causes for such behavior, like depression, or if there are other causes like hypoxia, can lead to such problems, then appropriate referral to the suitable specialist is needed, including a psychiatrist. If there's no reason for hostility, you can only apologize for the consultation not going well and politely disconnect the video call. Law says that a doctor has a right to accept the person as a patient, and the patient can't impose himself or herself on the doctor. In India, a doctor can reject a patient, a person as a patient, for any reason. You could just say, "I'm wearing a yellow color shirt. I don't like the color shirt. I don't want you to be my patient," and that is perfectly legal. The only thing in India a doctor can't reject is because of the religion of the patient. He can't say, "Oh, I'm a Christian. I'm a different religion. I can't see your patient, so I can't see it." That's illegal in India. But for all of the reasons, the doctor has to accept the patient. So there's no, the law protects us. Uh, what if you're not competent to deal with this patient? How do you cross refer basically? So after ascertain that the problem a patient's process is due to non-orthopedic causes, such as many of my colleagues, who are also doing e-consultation and they belong to other specialty, I'll refer the patient to them and explain the same to the patient that I'm referring to them, and I'll give them a referral letter also, transfer it electronically so that my colleagues can use that to see them. Since I'm a surgeon, how do I deal with telemedicine and surgery? So, see, as a surgeon, my main job is when the non-operative treatment fails, I need to seek a surgical solution, which physicians can't do because they're not trained in that. So I give these patients a physical appointment, either on an emergent basis or a casualty, or into my elective clinic for further management. Telemedicine, in fact, helps develop a doctor-patient rapport even before I've seen them for the first time. So it is definitely useful. How can you order e-pharma or e-investigation? So this is pretty simple. My center has a B2B agreement with the e-pharma platforms like MedLife, and they basically deliver the medicines to patients' home. And e-investigation diagnostic companies are also on the link, and they're happy to give a Uber or Ola or ambulance to the patient so that they can be transported to the investigation center, and then investigation done, and patient is transferred back to the house, and the report is sent electronically to my center or to me. So this is taken care of a long time ago, even before the corona. Lastly, I would like to answer a few of the question and answers which a lot of my patrons asked me in the last couple of days for the seminar. And it should not take much time. I'll briefly go through this. 10 questions basically. One is coronavirus more potent than H1N1? The answer is yes, it's 10 times more potent. And why is it so? Because it shares the genetic code with the human beings. So, and hence many asymptomatic patients don't even recognize it and don't even elicit a proper immune response because the genetic code matches. Second question, are younger patients safe? Is it so? It's the viral load which actually kills a patient, not the age of the patient. So any age sufficient exposed to sufficient viral load can kill. And those who are above 80, they already have a lot of comorbidities, so they are much more vulnerable. herd immunity after getting 60 to 80% infected, does it protect the elderly? I think Sweden, UK, US all made the mistake of herd immunity, and you can see the number of deaths which happened there. And it's almost impossible to separate grandchildren from granddads anywhere in the world. And I think, herd immunity concept is a flawed concept. We have to go for vaccination, and that's the only way to get proper herd immunity. Are homemade masks effective? They are basically effective in protecting others because they block the large droplets. So if you're infected, definitely the other person is protected. But you are protected from the other person only to extent of 70%. So I suggest that you use N95 or a 99 or a respirator. What is the best test today to diagnose coronavirus? It's RT-PCR. What is a CT count? CT count is a count where if it is more than 33 in the RT-PCR, that means the virus is not infective anymore. So I think you should insist that every lab which does RT-PCR should give the CT number. If it's less than 33, that means the patient is still infective. What is the ideal time to catch a virus? This is for the physios. If they expose themselves to a COVID positive patient for 15 to 30 minutes, they can get the virus, so they can limit the consultation to less than this time. Can you protect close to 100% from the virus? Yes, with the use of N99 or PARP respirators. What is the most important drug in coronavirus? If I ask any of you this question, you would say some antivirals, but the answer is no. Most important drug to treat coronavirus today is oxygen. Hence you need to home monitor your saturation with a saturation probe, and if it's below 94%, you need home oxygen. You can use prone position, which is very useful. In hospitals, we use low flow oxygen, like 2 to 4 liters per minute. Dexamethasone is very useful in stage 2 of the COVID disease, and also in cytokine storm, anti-interleukin 6, like tocilizumab, very useful. Antivirals like remdesivir are useful, decrease hospital stay by 4 days. Anticoagulants like aspirin are very useful because corona-associated coagulopathy is very common. So mainstay of treatment is supportive therapy. What's happy hypoxia? Patients with coronavirus can have a very low oxygen saturation, around 75%, still be walking normally. This has never happened before in other diseases. Normally, saturation falls below 90%, that person becomes breathless. And that's why you saw these patients falling off in Wuhan in the videos in January. They were dropping off like zombies. And this is because of happy hypoxia, where they don't realize that they are saturated 75%. So pulse oximeter can save these people. So as governments and the insurance regulators are pushing towards a home treatment for a lot of COVID patients, particularly in India, my center is planning to start a e-hospital where these 10% of 1.3 billion people can be guided from the comfort of their homes, and that's quite important. So watch the space in this. So I thank you again for a patient listening, and I thank Dr. Ismail Saeed for organizing this fantastic webinar. And I welcome any question and answers and ask him to take over. These are my contact details. If you need, you can contact me through my website or through my phone number or through emailing me. Thank you very much for your patient listening. I once again finish this thing by thanking Dr. Ismail Saeed for this great opportunity. Thank you very much.